Would plaque characterization add to the success of the fractional flow reserve testing? So, slides are not moving. That means I am a non-starter here. So, as you would see here, that the classic studies, European CAS study, the CAS study, VA, the Veteran Administration study, which had compared in the stable coronary artery disease, the revascularization with the medical therapy had demonstrated that revascularization, when you have the anatomic diagnosis of the disease, does better. So essentially more than 70% of the luminal constriction, and you have a better outcome with the revascularization. These were the days when the plaques were juicy plaques. You did not have the statins and all other preventive therapies that you have an access to. But for the time appropriate optimal medical management at that time, the revascularization was expected to be better, not only for the short period, as you would see on the left-hand side, only about 5 years follow-up. Even in the extended trials, you saw that this benefit, it was maintained up to about 12 years when the extended European CAS study was demonstrated. Now, this, as Dr. Pappas just demonstrated, that the Berry 2D trial and the Courage trial also came, that also negated that essentially only looking at the anatomy may not be as useful, because with now the time appropriate therapies, now the therapy has improved significantly, that the treatment, whether we use the revascularization or we use the medical therapy, the outcomes at 5 years happen to be similar. And that is something which led to a significant decrease in the number of the interventions after these two studies were presented. At that time, it was being shown that it is not essentially the anatomic presentation of the disease, but we must go after the physiologic importance or physiologic significance of the disease, because the anatomy essentially may not be what is represented by the physiology of the disease. For example, in this case, you can clearly see that approximately 20% of the people who have less than 50% stenosis may have abnormal FFR, and on the other hand, significantly stenotic lesions, more than 70%, and about 20% of the people would have a normal FFR, suggesting thereby that anatomy and physiology may go hand in hand, but there are multiple cases on the two sides which may not confer or which may not be congruent in this particular case. And that is something which was shown to us by the FAME study, the first flow reserve study, fractional flow reserve study, where it demonstrated to us that, got to go back. Yeah. So, as you can see here in this particular case, that these are the subjects who have been treated based on the angiography and the subjects which have been treated by the FFR-based strategy. And you would see that there is approximately 33% benefit to the people who have had the FFR-based strategy. So, essentially, the death and MI, they are about 33% less in the subjects who were treated by the FFR-guided strategy. However, when you go by the vessel-based analyses in these cases, you find that the entire advantage or entire benefit of the FFR comes from the group which was FFR negative group. Now, essentially in this group, you would see that out of 1,000 subjects, you will only have 2 events if the FFR was negative, suggesting thereby that there is a high negative predictive value of doing an FFR, that if the FFR is normal, you would not have an event. On the other hand, when you look at the FFR positive cases and compare them with the angiography guided management, you will see that the difference is not too significant in these cases, again suggesting that the positive predictive value of having an abnormal FFR may not be very high. Now, when you look at the FAME2 study, the second in the series, where the people who had abnormal FFR and they were subjected to receive either the optimal medical therapy or the revascularization. In this particular case, you see that the subjects who received the revascularization and optimal medical therapy compared to only optimal medical therapy, they did a lot better. And that was the time when it became a gold standard that we have got to do the FFR as a class 1 indication for the management of these subjects. And as you would see in the FAME2 study, however, that the difference between the death and myocardial infarction in these subjects, if you will see that it was about 7.1% in the people who were treated by the revascularization and optimal medical therapy versus 8.6% in the subjects who were only treated by the optimal medical therapy, again suggesting that the positive predictive value of the FFR is not very high. You only have approximately 8% advantage. You have to do 100 cases to be able to save 8 people from having a death or myocardial infarction in these cases. So now we have heard multiple times that it is the plaque morphology which is important, because the events that occur, they occur because of the high-risk plaque or the plaques which are vulnerable to rupture. So in this particular case, you would see that we have the left anterior descending coronary artery on the CT angiography, and here you will see that there is a significant positive remodeling. There is a huge lipid or the necrotic core that you can see, what we call as the low attenuation plaques in this particular case. And if these two features are present, as we call them as two-feature positive plaques, there is these plaques are likely associated with the patients who have developed the acute coronary syndrome. And as you would see here, that this is the positive remodeling in the people with acute coronary syndrome and low attenuation plaque in the people with acute coronary syndrome as compared to those who are the stable coronary artery disease. And then you would see that the plaques, which are the fibrous plaques, obviously will be present in both the patients who have acute syndrome or who have had the stable disease. And finally, you would see that there is more likelihood of having the spotty calcification or the small calcification in the cases who have had the acute coronary syndrome. The larger amount of calcification is normally associated with the stable coronary artery disease. On the other hand, when you look at the stable disease in this particular panel, you'll see that there is no positive remodeling, there is no low attenuation plaque, there is only luminal constriction, and this is the patient who has had the stable coronary artery disease. But now the question is, can we really prognosticate the patients if we have such features, but if the event has still not occurred? Would we still be able to identify the people who are likely to have an event over a period of time? So here is our study with 3,000 subjects, 10-year follow-up of CT angiography, and you will see that the subjects who have had the high-risk plaques, they do much worse as compared to the subjects who did not have the high-risk plaques. And you'll see that there's a 10-fold higher likelihood of having an event if there was a high-risk plaque over the next 10 years' time. Our previous study, which was 1,000 subjects and 2-year follow-up, we had demonstrated that the people who had high-risk plaques, these people do much worse as compared to the people who did not have high-risk plaques. And at that time, we had found that there was essentially no events over the next 2 years if the high-risk plaque was not present. However, the euphoria that we had at that time was proven wrong, because as you go over the next 10 years, you see that there is a likelihood of some of these people who had non-high-risk plaques, they develop the high-risk plaques over a period of time, and they can result in an event. So approximately 3% likelihood, 2.7% likelihood here, and 9 to 10-fold higher likelihood of having an event in this particular case. We further found out that if there was a high-risk plaque and it was also associated with the significant stenosis, there was a much higher likelihood, 7-fold higher likelihood of having an event as compared to the plaque which was a high-risk plaque but did not have significant significant stenosis, suggesting thereby that these plaques have to become bigger or they have to enlarge over a period of time before they really become susceptible to the plaque rupture and an event. And that was demonstrated in a subset of the same study where we had approximately 450 subjects who had two CT angiograms over a period of 1 year. And we demonstrated that if there was a high-risk plaque and it demonstrated the plaque progression over the next 1 year, there was almost 30 times higher likelihood of having an event as compared to the plaque, which was a high-risk plaque, but that did not progress over the next 1 year. And that these were the plaques which were not going to have an event as compared to the one which had demonstrated the plaque progression. Now, if we look at that, and if we look at the FFR, is there a possibility that there is some kind of a relationship between the two? So if FFR is a physiology, what if I call it a pathophysiology here? What if I say that there is a possibility of an interplay between the plaque stenosis and the kind of the plaque that we are dealing with? Would FFR be determined by more of a pathophysiology than only the stenosis which we have always thought of? So the reason that the FFR always has been felt to do well, again, when the FFR was first described, these were the days, again, when there were no statins and all the plaques were the atherosclerotic plaques. And essentially, it must have been quite different in those days than the kind of plaques that we encounter in today's day and age. So as you would see here, that this is a very elegant study that comes from Dr. Akasaka's group from Japan, where he looked at two important things: adverse hemodynamic characteristics and advanced plaque characteristics. And the advanced plaque characteristics here are based on CT angiography as well as some of the optical coherence tomography compared to the adverse hemodynamic characteristics, which are based on the FFR in this particular case. And as you would see here, that as the FFR becomes more and more abnormal, there is a higher likelihood of having an event. And as the number of the adverse plaque characteristics, that is, the plaque is becoming more and more high risk, as you would see there, there is a higher likelihood of having an event. And then if you put the two together, you will see that if the FFR is less than 0.6 here, there is a much higher likelihood of having the adverse plaque characteristics as compared to the normal FFR, where you hardly have any adverse plaque characteristics, suggesting thereby that there is some kind of a relationship between the two. And here comes our study, which is the NXT study, and it was a reanalysis of the NXT study, where we had availability of CT quantitative stenosis. We had the availability of CT FFR, invasive quantitative stenosis, and invasive FFR in these cases, as well as we had an access to the plaque characteristics in these cases. And if you look at it, look at the FFR as to what were the best determinants of FFR, and our obvious expectation would be that it is the luminal constriction or the QCA. And yes, it indeed shows that there is significant relationship with the QCA. So more the luminal stenosis, more is the likelihood of having the abnormal FFR. But to our surprise, as we were really thinking that would plaque pathology correlate with it, you will see that it did even better than the luminal stenosis. Now, it was difficult to explain. It was quite an intriguing finding that as to why something which sits out of the lumen that controls the FFR in these cases, or fluid dynamics in these cases. And what we found was that it is essentially the area remodeling. And that was our next paper after that in Circulation, where we had demonstrated that these areas where there is a large necrotic course, their smooth muscle cell layer or the medial layer is completely extended. So it is totally dilated and it cannot go any further, something what you know as the Glagovian limit, or the limit which was demonstrated by Glagau. And in such a case, if you give them the nitroglycerin, if you give them the adenosine, whatever you do for the FFR, at that time, on one hand, you are acting on the distal vasculature and you are paralyzing the smaller or microvasculature. On the other hand, you are also causing the dilatation of the epicardial arteries. And since the smooth muscle cell layer has gone to its maximum, it cannot go any further, while the proximal part of the artery and the distal part of the artery, they normally dilate, and this area creates a bottleneck or so-called functional stenosis, so that the FFR becomes abnormal, and it provides the validity to the FFR as the prognosticator in such cases. So we demonstrated that with in collaboration with Dr. Knappen from Amsterdam, that we did the PET studies and compared them to the FFR as well as the adverse plaque characteristics. And as you would see here, that the ischemia was essentially related to the same three features which I had talked to you earlier about: low attenuation plaque, positive remodeling, and the spotty calcification. Now, based on that, we tried to reanalyze the FAME data here. And as you would see in the FAME data, that if there is the normal vessel, quite like what you will see here, that the FFR happens to be normal in this particular case. And then they have got the 50 to 70% angiographic stenosis and 70 to 90% angiographic stenosis. Now, the people who have 50 to 70% angiographic stenosis, they have normal FFR or abnormal FFR. If they have normal FFR, the likelihood would be that their lumen is not significantly stenotic, as well as that they also do not have a significantly large low attenuation plaque or large necrotic core. Essentially, these are the people who are not going to go anywhere in terms of an event when you have no large attenuation plaque. And if you have a large attenuation plaque and the FFR is low because of that, then essentially there would be an event in this particular case. So FFR turns out to be a right kind of an indicator which differentiates between a normal or non-lipid-rich plaque, and if this is an abnormal FFR, it describes the lipid-rich plaque even in the absence of luminal stenosis, suggesting thereby that it would be the best prognosticator in this particular case. Now we come to the 70 to 90% stenosis, and what did you find in this particular case? That if it is the normal FFR in this case, and again I have given you the numbers in that particular study, it must have been that it is 70 to 90% luminal stenosis, but it is still okay because it is able to dilate reasonably well, and it would not result in the ischemic symptomatology or events in future. On the other hand, if it is less than 0.8 FFR in this particular case, it could be explained by two things. Either it is severe stenosis or it is the modestly severe stenosis, but there is a large necrotic core in this case. And again, this will determine that there is a higher likelihood of having an event in these cases. Now, that has been shown very elegantly by Dr. Habib Samadi, who did the reanalysis of the cases from FAME2 study. Now, this particular group of subjects, they are only the ones which were treated by the medical therapy. And it was a very clever design of the study, and they looked at just the simple angiograms that were available to them, and they did the wall shear stress in that, and they found that wherever the high wall shear stress was, that they were related to the higher number of the events. And high wall shear, as you know, is determined by the plaque vulnerability or plaque morphology in such cases. So patients being treated less than 0.8 FFR being treated with the medical therapy. And what you find in this case is that approximately 50% of them had normal wall shear stress or low wall shear stress, and 50% of them had abnormal wall shear stress. And this abnormal wall shear stress is related to much higher events in such a case. And 50% clear-cut differentiation in these cases. And if you really look at the 5-year outcome of the FAME2 study, which has recently been presented, you similarly find that 50% of the people, even after 5 years, with abnormal FFR, with optimal medical therapy only, are able to do very well without a need for revascularization, without medical therapy, without myocardial infarction, without death. And even their anginal scores are similar to those who crossed over to the revascularization side, suggesting again thereby that you could have easily avoided interventions in 50% of these cases who would have done well on optimal medical therapy. So, can we really change our paradigm here? So what we used to think, what we think, and what we should be thinking. So if we look at these three here, so what we used to think, anything beyond 70% should undergo revascularization. And when we added the FFR to it, as we discussed, that 33% of them could be bitten off. These 33% of people do not require any intervention. And then we go further, and if we are able to identify the high-risk plaques in these cases, we would be able to take away, quite like what Dr. Samadi's study demonstrated, we can take approximately a 50% of a bite again here, leaving only 33% of the lesions, which essentially require revascularization. And so this would really economize, as well as this would be the most important benefit to the subjects if we can identify such plaques. So now, is there a possibility? How exactly can the CT angiography help us in these cases? Now, there are multiple things which are being brought in to the CT field. For example, here I'm just trying to demonstrate that approximately 10 to 20 years ago, we only used to think in terms of how much is the luminal stenosis, how does the plaque look like, or how is the calcification in these cases. And now, as you know, that we can also do the physiology on the CT angiography. We can easily, by using the computational fluid dynamic features here, we are able to identify as to what would be the FFR, and it will be quite parallel to what we see in the invasive labs. So, here, for example, in this particular case, you will see that the FFR can be identified. If it's the lesion, if you look at this particular lesion and you want to see the fall of the FFR across this particular lesion, it goes from 0.96 to 0.78 in this particular case. What you would have done in the angiography lab was you would have gone to the distal end and you would have identified the 0.71 in this particular case. Now, as you have seen that these two studies, the platform study, the PROMISE study, and then the PROMISE FFR CT study, that normally if you will go with the FFR CT guided management, you'll see that only about 12 to 15% of the people will have a non-obstructive disease not requiring the intervention. On the other hand, if we had only gone by the usual care, it would have been in 72% of cases. If we had gone even after the functional testing, it would have been 52%. And simple CT angiography without the FFR CT, it would have been approximately 28%, suggesting thereby that adding the FFR physiology to the CT angiography non-invasively, we are able to reduce our unnecessary caths down to 12 to 15% in these cases. Yet another possibility that is coming in, and we just submitted this particular paper, which is looking at the approach score. And that was the comparison of the CT angiography, looking at the FFR values, after the stuff which is distal to the lesion, and looking at the MR perfusion with it, and trying to identify the amount of the myocardium at risk, that you will be able to essentially identify that if this particular lesion gives in, then how much of the myocardium which is subtended by this particular artery will be lost over a period of time. And then something which has just been approved about 2 weeks ago by the FDA, something what you call as the FFR planner. And the FFR planner is that you can put in a virtual stent at the place of the stenosis, and you'll be able to see as to how it would relieve the ischemia in this particular case. And here you would see that you are putting in a virtual stent, and it will be able to tell you as to what the result is going to be and what the FFR would be in this particular case. And let me give you an example here of a focal disease and the diffuse disease in this particular case. And here you can see that there are two lesions in this particular area, or I think I should, just to make it shorter, I should come here first. That if you will see that there are two lesions here, the lesion A and lesion B, and looking at the numbers that you are getting by the FFR, invasive FFR, you essentially are going to go after the lesion B. And if you will see what is happening in the CT angiography and the FFR as well as the FFR planner that you have, that the lesion which is really causing the drop in the FFR in this case is the lesion A and not the lesion B, which you could have identified ahead of the procedure. And essentially that could be that probably it must have been a much bigger necrotic core in this area, even if you do not see much of a luminal stenosis in this particular case. You will see that this is the lesion which is indeed causing the symptoms in this particular case, as has been shown here, that this is the lesion B, here is the lesion A. And if I had just corrected the lesion A, I would have gotten the normal FFR in this particular case. However, if I had gone after the lesion B, I would not have achieved the non-ischemic status in this particular case. And the last important thing that I would like to talk about here is that now we can add the plaque characteristics to it. And I'll give you one of the examples. One of our patients, 72 years old male, he had a typical chest pain, came with the past medical history of dyslipidemia, and he was on rosuvastatin 10 milligrams. He had a strong family history of premature coronary artery disease. His father had myocardial infarction at the age of 50. They found out to have a non-calcified plaque in the mid-LAD, about 25 to 50%, and there were some other scattered segments, all less than 25%. The CAD-RAT score was 2. Now, in this particular case, when we did the FFR, as you will see here, that there is a significant drop in the FFR at that particular lesion. So it drops to 0.76. And when you look at the plaque characteristics, you will see that there is a huge necrotic core in this particular case. And then talking to the patients, he said that he would not like to go for the intervention. He would not like to go for the invasive test. We discussed about it, and we started him on 40 milligrams of rosuvastatin and ezetimibe on that day. Patient came 6 months later, does not have any angina further. And as you would see that this is the necrotic core, it has decreased significantly. And as I told you, that plaque progression is something which is really important for the event to occur. In this particular case, you will see that there is a significant reduction in positive remodeling, there's significant reduction in the necrotic core. And can you give me the next slide, please? Yeah, thank you. And so at 6 months follow-up, now we will do the FFR in this particular case. And what do you see? That the FFR has also totally normalized, suggesting thereby that it provides us an opportunity that we will be able to deal these cases with the medical therapy, and would obviate the need for revascularization. So regardless of the guidelines, as what Dr. Fuster was telling me, when it comes to logic, I will still bat for the CT angiography rather than functional testing. Thank you very much.